السلام عليكم جميعا حياكم الله. We are having a little bit of technical difficulties on the moderator's end. Hopefully it will be resolved shortly. I'd like to start off by introducing myself. My name is Dr. Smair Raed Ruslan. I'm assistant professor at King Saud University, a consultant cardiologist who specializes in advanced heart failure, heart transplantation, mechanical support, and cardio oncology. It's my genuine delight to be here today to continue with another part, another journey to discuss hypertrophic cardiomyopathy, which is a very important topic that is gaining a lot of momentum. And in our continuation, today we're going to focus more on the symptoms and solutions, so navigating the diagnosis and management of HCM. These are my disclosures. And Prof. Kamal Ghalayini would be giving us an introduction and overview of hypertrophic cardiomyopathy. But given the technical difficulties, I can fill in that part and then delve into my own part. Starting off with a case. So you see that this is a 43-year-old female who had an event of ventricular tachycardia while she was at the gym. So symptoms by history is NYHA class 2 symptoms. She thought that these were actually related to her being out of shape, and that's really why she went to the gym. She also has occasional palpitation. What's also relevant that she had her father die at the age of 50, and her brother drowned despite the fact that he knows how to swim. She doesn't take any medication. She has no allergies. The social history is unremarkable. And, she has a full set of workup. And as part of the workup, she has an echo. And the echo showed that she had a significant LVOT gradient at resting and on Valsalva. And that really prompted more investigations and more testing. So I want you to keep this in the back of your mind, thinking about, how am I going to approach this? What are the certain things that I'm looking for? How am I going to risk stratify? What are the interventions and what are my goals? And as we proceed forward, hopefully a more clear and crystallized mode of action will emerge for you. HCM is common. It's about 1 in 200, depending on the reference that you're reading. Definitely, it's underdiagnosed, and it's associated with a wall thickness that is more than 15 millimeters in one or more LV myocardial segment that is measured in any technique. And as you can appreciate over here, the normal heart to the thickened hypertrophied heart as well. We've been through a milestone since the beginning of the description, histological description, up until right now. It's been about 155 years. And I want to point your attention to a few important landmarks, aside from the fact that we identified it in post-mortem. Braunwald in 1964 described it in case series. And then we have the Broken-Burrow effect on invasive cardiology. And later on, we described the first genes back in 1990. But it's only up until 2003 with Barry Mason and Willem McCain from Europe. They generated a document where this was the first collaboration between Europe and the ACC. Thereafter, they took different paths, and afterwards, the guidelines continues to emerge thereafter separately, 2011, 2014, and then back in 2020 when the American ACC guidelines came out. And then after the European guidelines, there was the Pioneer and Hunter trial that was presented by Hunter back in 2019, and then followed as well by the Explore HCM. And we'll get to that as we proceed forward. But what I can tell you is this is a progressive field, and we've made so much accomplishment. But really, in the last 7 years is where we've done much more than we've ever done before. And we expect things to continue to progress forward. As you are aware, there are several different types of hypertrophic cardiomyopathy, such as sigmoidal, reverse curve, and apical HCM. But the most common type is the asymmetrical septal hypertrophy.
Recording in progress.
And once you look at the pathophysiology of HCM, there are three different main effects that we see. So you appreciate the ventricular thickening that takes place. There's also evidence of valvular dysfunction, and also there are changes at the level of the cell as well. And we will skip that for the time being. But really, what you really need to decide on early is, does my patient has obstructive hypertrophic cardiomyopathy, so a gradient that is more than 30, with or without systolic anterior motion of the mitral valve? And this is primarily 70% of the cases. And does your patient have non-obstructive HCM, which is less common, but also present? And that's why you need to have a high degree of suspicion once you are proceeding, and to really decide early which phenotype of these is your patient. And, LVOT is caused by structural changes, and it can be dynamic. And you can notice that because of the narrowing of the LVOT, the anatomical changes that you appreciate on the mitral valve, and the systolic anterior motion. But again, the key factor here is you need to look for it. You need to really spend the time necessary for provocation if you have a suspicion, seeing a thick heart like you see over here. Okay. So the other question that might come is, sure, I understand that. That's a good point. But how am I going to make the diagnosis? How is the patient going to come to me? What are the avenues where I should be considering a working diagnosis of hypertrophic cardiomyopathy? And to me, these are the avenues where you might be consulted. Irrespective of your area of practice, I think these primarily functions should be where you're looking. So somebody who comes in with exertional symptoms, so you work them up for shortness of breath, and then you proceed with your working diagnosis. If you have somebody who comes in for routine screening, and then you identify that there's an abnormal physical exam, especially with maneuvers. If you have somebody with left ventricular hypertrophy that is significant, asymmetrical on echo, if you have an abnormal suggestive ECG, or if you have family history of maybe somebody who already has the disease, or maybe somebody who had sudden cardiac death, like our patient from before. So our patient from before started off the story of her actually having an episode of syncope with VT. She also later disclosed that she had exertional symptoms. She also disclosed that she had family history, and she had evidence of significant left ventricular hypertrophy on the echocardiography. So what are the certain tests that you need to look for? And to me, at least these are what should be in the back of your mind. And thereafter, you would decide, do I need more? Do I need less? And why do I need them, and what am I looking for? So an ECG is always fair game, an echo as well, especially with provocation testing, looking to see whether there is a provocable gradient or not. And also, you need to get a full family history. So when we say a full family history, you need a 3 to a 4 pedigree. Also, you can consider a cardiac MRI, ambulatory Holters, and biomarkers such as BNP, troponin, and also genetic testing. When you're approaching a patient with HCM, really you have to keep in mind that the physical exam is very powerful. So if you're looking at the carotid, you can notice that there's a rapid carotid upstroke. You can appreciate a pulsus bifrensis, spike and dome. And you can also appreciate that there's a triple wave at the apex as well, early systolic wave, a late systolic wave, and also an S4. But also you can appreciate your left parasternal ejection murmur that changes with maneuvers. So this is the time when you do a Valsalva or a standing maneuver. But also you could appreciate sometimes mitral regurgitation with deviation to the apex. And over here, you can appreciate an echo, an ECG that shows basically left ventricular hypertrophy, T-wave changes as well in the pericardial leads, but also one of the pathognomonic signs is deep T-wave invergence in the pericardial lead, which is very suggestive of apical HCM. Other things can be considered, such as invasive testing in the cath lab, a cardiac MRI, but really the gold standard and what's going to give you the answer and clue you in is an echocardiogram. So looking to see if you have evidence of asymmetrical septal hypertrophy, more than 15 in any of the segments, and looking into the gradient that is appreciated on a CW across the aortic area, and looking to see this dagger-shaped appearance as opposed to your different circular aortic stenosis appearance, and spending your time trying to justify whether this ventricular hypertrophy is associated with a gradient or not. And you need to keep in mind what are the burdens and the complications. So what are the things that are in the back of your mind once you're seeing this patient as you're making a diagnosis? So they have the deliberating chronic symptoms, they have decreased functional capacity, there is the risk of atrial fibrillation and thromboembolism, sudden death, and heart failure. And these are the things that you're going to notice as you build a relationship with your patient. And these are the certain things that you are going to tackle as you move forward dealing with your patient. Over here, you appreciate a parasternal long axis view of a patient with HCM, and you can appreciate that there is significant asymmetrical hypertrophy. And over here at the bottom left, you can appreciate on the CW that the peak gradient is 19. And it looks very nice and circular and well-defined. But again, it's only when you proceed to do provocation testing is when your gradient changes all the way up to 63. So now we are in obstructive HCM domain. And this is why that you need to use multiple imaging modalities. You need to use what's available for you, and you need to try to really investigate looking for it. So on a PW, that would be helpful to help you define the site of obstruction, but the CW, as you all know, will help determine the degree of obstruction. And if that's not helpful for you, then you can consider other imaging like TEE, a cardiac MRI, whatever you need to do to actually close this loop and make your diagnosis, because the management really depends on whether it's obstructive or non-obstructive. And this is a really nice paper that was published in JACC around the end of the 2002s that shows you that the change in LVOT gradient from rest to post-exercise, and it's a very significant variable change that you do. So we're doing our patients a disservice if we really don't spend the time looking for these gradients. And as per the ESC guidelines, it's a class 1 indication to go in and really interrogate and try to find the gradient in these patients, because that is where you would risk stratify your patient accordingly. Other methods of basically of exerting the gradient is using a Valsalva maneuver. So over here, you can appreciate a resting LVOT gradient of 8. You do the Valsalva, it goes up to 36. And when you do the exercise, it goes all the way up to 87. And why are we doing that? We're doing that primarily to reclassify our patients. And as you can see, once we start off with an obstruction at the LVOT that is more than 30, then basically you have resting obstructive HCM. Now, if you have obstruction that is evident with Valsalva maneuver, so this is what we call a provoked obstruction. If you do it with exercise and the gradient goes up more than 30, then that is also provoked. But if you do these things, you do a Valsalva, you do an exercise, and you're not able to increase the gradient, then that's basically non-obstructive HCM. So this is why it's very important to spend the time and get the diagnosis. And as we mentioned, up to 50% of the time in surveys, the centers have not performed appropriate provocation with their patients that are suspected of HCM. And at this point, you would continue to do provocation, such as standing, such as Valsalva, and also exercise. And you can consider postprandial exercise for these patients. MRI is a very strong and powerful tool. And what you can see in the first image over here is a hypertrophy of the anterior and anterior septal myocardium. And in the B image over here, along with the arrow, you can appreciate late gadolinium enhancement in the hypertrophied anterior septal myocardium. Also, the MRI in this image helps provide you with a lot of information. So this is telling us that this is a mid-ventricular hypertrophy with apical aneurysm. And we'll get to the apical aneurysm later because it's one of the risk stratifying criteria that we have in our patients. But also what coincides with this apical aneurysm, you can appreciate over here, is also there is evidence of enhancement in this area. And this patient had VT. One of the questions that we get asked a lot is living with the disease. And I think that's one of the difficult discussions that I have with my patients. And essentially, one of the biggest questions that they focus on before they talk about their symptoms and how am I going to get better is what's going to happen to my offsprings? What's going to happen to my current children? Am I going to be able to have children? Are they going to have the same disease? And that's why it's really important to have this holistic approach with your patients to tackle the several domains that we have mentioned before in your management. Because the disease burden is very high and the mortality is higher about 3 to 4 times than the general population, and this varies from heart failure, atrial fibrillation, sudden cardiac death, and the one that worries us the most is sudden cardiac death. So, there's a lot of algorithms out there, and there's the ACC algorithm and the ESC algorithm, but really I find this algorithm to be the most simplistic way to actually work up your patient with a suspected HCM. So if you have somebody who's suspected by HCM, it's either going to be by personal history or symptoms. They're going to have a physical exam finding that is positive, or they're going to have a family history of HCM diagnosis or sudden death in the family. So what are the testing domains that I should consider? An ECG, an echo, a cardiac MRI, and you can consider if it's available for you doing genetic testing, looking for specific known sacromeric HCM variants, because that would also help you risk stratify the offsprings. So once you identify HCM, your role right now is to decide whether this is obstruction or it's not obstructive. So if you have obstruction at rest, as we mentioned before, so this is resting obstruction. And if you have no obstruction, then at that point you would try to provoke it. So this is provocable obstructive HCM. If you have access to genetic testing, then you need to decide whether you have gene positive and phenotypically positive. By that, we mean we identify a gene, let's say in the patient that we saw before. And after that, we decided to test her children if she has some. And if they have the gene, we do screening. And if the screening is positive, then basically we continue to follow them over time. And then if the gene is positive and they don't manifest at this point, then at this point, your role is to continue with screening in the event that it's going to appear in the future. But if their gene is negative and they're phenotypically negative, then really you don't have to continue screening these patients over time. And we'll get to that somewhere in the next 10 minutes. So the guidelines out there, there's the ESC guidelines and the European guidelines and the American guidelines. They really share most of the spirit and the body of what you need to do with small, subtle differences in the management. Now, the European guidelines tells you that if you found somebody, we went through the algorithm before and we identified somebody to have a resting or a provocable gradient that is more than 50, and they have symptoms. So again, we have a symptomatic provocable gradient. At that time, the first line therapy is basically to consider a beta blocker to the maximally tolerated dose and to see if that actually relieves their symptoms and relieves the obstruction that they have. And if they're intolerant or still symptomatic, then basically you can consider verapamil or diltiazem. If they're still symptomatic, then on top of that, you can consider disopyramide. Now, if you look at this graph over here, really we're tackling everything outside of where the problem is. And we haven't went through the pathophysiology in this part of the lecture, but essentially this is a sacromeric problem at the level of the actin-myosin chain, and we haven't really tackled that. So beta blockers, calcium channel blockers, and disopyramide. So really, right now, in the new era that we are right now, we have medication such as mavacamten that are available for us. So we're tackling the issue of the matter, so to speak. And this is what you find mentioned in the European guidelines, and it was given a class 2A indication to consider myosin inhibitors. And if they remain symptomatic, then the next step is going to be septal reduction therapy. What about the American guidelines as well, in a very similar spirit in the beginning of these patients? So you see them, you make sure they are obstructive. So if they have symptoms, then basically they tell you that, of course, you need to avoid vasodilators and high doses of Lasix, and you give them beta blockers, verapamil or diltiazem. If they remain symptomatic, then class 1 indication for a myosin inhibitor, disopyramide, and septal reduction therapy, which is also interesting here because if you notice, they are all on the same level. And also you notice that disopyramide is at the same level of evidence, though it has nowhere near the evidence that the data is available for mavacamten. And again, they also here lump up mavacamten as myosin inhibitor as a class, as opposed to the European guidelines where they explicitly mention mavacamten. You also notice that there is no step down between the medical therapy and the surgical therapy. And realistically speaking, this is really what happens right now in the contemporary clinic. So you get your patient, you talk to them, and you tell them about what's available for you, the new oral therapies that are available, and septal reduction therapy. And it's shared decision making. Again, you need to see if they are a surgical candidate. So if they're not a surgical candidate, then consideration for septal ablation can be made. If they are a surgical candidate, you need to ask yourself, do I need to go in and do something else? So do they have coronary artery disease? Do they have abnormalities in the mitral valve? And as you are aware, there are structural abnormalities in the insertion point, and the pap muscles and the leaflets. So you might actually need to go in not only for the HCM itself, but also because of another surgical indication. So at that point, a myectomy seems to be like a reasonable approach. And if that's not the case, then basically you can consider septal reduction therapy or myectomy. A little bit about septal reduction therapy. So we lump them up together, and basically they're a combination of surgical myectomy or alcohol septal ablation. So surgical myectomy, the surgeon goes in and they basically remove the hypertrophied segment and they relieve the obstruction. Alcohol septal ablation, they go in through a typical angiogram, much like you're doing your regular day-to-day angiogram, and then you basically conduct a controlled myocardial infarction in this area of the hypertrophied septum that causes basically resolution of the obstruction. This one versus that one really depends on what we talked about before, but also depends on your center and what is the expertise available for you. But in general, the outcomes are really good for both. So the mortality at 30 days is almost comparable. The adverse effects are almost the same, but you have more complete heart block with alcohol septal ablation, and the likelihood of repeat operation is higher in alcohol septal ablation. But in the end of the day, what really guides this discussion is what's available in your center, what's the likelihood of success. But the majority of these patients are able to get their gradient under 50 after the procedure. And this is an example over here of a patient who had obstructive HCM, and they underwent alcohol septal ablation. That's why you see it's white over here. And then the peak gradient went down from 51 to 15. Switching gears right now to the cardiac myosin inhibitors with regards to the recent clinical data and applications in HCM. The first is mavacamten. It's a small molecule that causes allocytic inhibition of the cardiac myosin, and also it was introduced about in 2016. And basically what it does is it reversibly binds to the cardiac myosin in an allocytic site. To really help drive this point home, mavacamten really is a targeted inhibitor of the cardiac myosin that reduces the number of myosin cross-bridging. So basically decreasing the contractility. In a more simplified fashion, what you're trying to do is you're trying to change the contractility from a Bugatti into a big truck, essentially, with these types of medication. So it's been a very long time, and a lot has happened since the first 2016 Pioneer HCM trial, followed by the Explorer HCM and the Valor HCM trial. And to start off, we're going to talk about the Explorer HCM. So the Explorer HCM was a phase 3 multi-center randomized double-blind placebo-controlled trial in 68 clinical centers in 13 countries. And they looked to compare the effect of 30 weeks of mavacamten with placebo on clinical response that was compromised of exercise capacity and clinical symptoms in subjects with symptomatic obstructive HCM. There were secondary objectives such as the LVTO obstruction that was evaluated with echo, and also exercise capacity, clinical symptoms, and patient-reported outcomes, and also the safety and tolerability of mavacamten. So the patient had to be class 2 to 3 symptoms, at least one provocable gradient that is more than 50, or with provocation at screening, and the Valsalva LVOT that is more than 30, and they got randomized to a 1-to-1 fashion to receive oral mavacamten. And there were several stops along the way where titration of the doses can take place. And basically, they continued on placebo versus mavacamten, and then basically they go off of the therapy thereafter after 30 weeks. And this is the primary endpoint. So the change from baseline into week 30, so a change of more than 1.5 ml per kg per minute of PVO2 with a more than 1 NYHA class improvement. The composite number 2 was a 3 millimole per kg per minute PVO2 with no worsening in the NYHA class. And the primary endpoint can be met if you met either 1 or 2. And the secondary endpoints are what we talked about. So the post-exercise LVOT gradient, the peak VO2, NYHA class, and basically the overall reported symptoms. When you look at the baseline characteristics, they were very well balanced. I want to point your attention that in this trial, there was no patient that were on disopyramide. Look at the age group, and it really tells you an idea of whom you're likely going to see in your clinics. 58 plus minus 12. Also, their NYHA class was very well balanced. Atrial fibrillation was about 10. And basically, they have a BNP that is elevated. And genetic testing was done as well in these patients, but not in all the patients. When you're looking into echocardiographic parameters, as you can tell, they have super high EFs in these patients. The maximal thickness is around 20. The resting gradients are high as part of the recruitment criteria, but the LV2, the LVOT gradients with Valsalva is around the 70s, and it goes up with exercise. And you can tell these changes that are taking place, and these are the things that we talked about previously when it comes to doing your echo and looking for the gradients and exploring where you are. Because even when you are on therapy, you want to make sure that you're revisiting these parameters again to look to see if your parameters and if your patient is responding. And to no surprise to everyone, the primary endpoint was met. There was an improvement in their PVO2 and their NYHA class. Looking into the secondary endpoints, so the post-exercise LVOT peak gradient, and I want to point your attention to this significant difference that took place over here. So this is the baseline. This is the mavacamten group. And at week 30, it went down all the way to 38. So there's about a 47 millimeter mercury difference that took place, as also, which is not unexpected. The patients on the placebo group had a minimal change. And this is where we looked into the peak VO2 in these patients. There are very minimal things that actually change your peak VO2. And the fact that you were able to change that in a short amount of time is really a point where we have to appreciate. In the heart failure world, a peak VO2 that is less than a specific number, to me, is, the difference between putting your patient on advanced heart failure therapy versus not. And again, you notice that your patient had an improvement in more than one in their NYHA class, about 65% of the patients who were treated. Also, you could appreciate the reclassification of your patients that took place after. And what you can also appreciate is your patients that are becoming more class 1 as you proceed over time, but also you can appreciate that the class 3 is also getting smaller in these patients and the class 2 is getting smaller. But this is also persisting over time as you continue to go forward. And there hasn't been a big, significant, meaningful change as is expected in the placebo group. Other things that was also looked into, so basically the Kansas City questionnaire, and what you appreciate is on the red over here is the mavacamten group, and on the bottom is the placebo, and you can appreciate that there is an improvement, and the improvement is going upward. And on the right side, which is the HC MSQ, which is a shortness of breath, basically subscore, that was also used, and you can appreciate that there is a significant change from baseline in these groups. And of course, what's also worth mentioning is once they go off their medication, they feel really bad, and it goes back to almost the same baseline to the patients who are on placebo. If anything here, it's actually a little bit worse. What about the side effects? It was really very well tolerated, and 97% of these patients completed the entire thing up to 30 weeks. There were 3 patients who discontinued due to adverse effect in the study, 2 of them in the mavacamten and 1 in the placebo group. And also, there was no withdrawal due to reduced ejection fraction. And to me, when I was reading the literature 10 years ago, I was really concerned about what was going to happen to the ejection fraction because, remember when we talked about the Bugatti and the truck, you would expect to see something of that sort. And this is the answer to that point. So over the course of the study, the change in the LVEF and the mavacamten group was about 3.9%, and basically in the placebo group was 0.01%. So, and again, this was not statistically significant. It was not a meaningful change, which is also reassuring. Switching gear to another important trial, which is the Valor HCM trial, which was a randomized double-blinded placebo-controlled multi-center phase 3 study in the United States that evaluated the effect of mavacamten treatment on reducing the number of septal reduction therapy performed on ongoing septal reduction therapy eligible patients with symptomatic HCM who are eligible for that. And the objective of that to see if who will remain basically eligible. So to simplify this even further, imagine yourself right now in the clinic. You're working your way through the algorithm. You've reached the end of the algorithm. And based on this algorithm, this patient is a candidate for septal reduction therapy because I've done everything I can do and they remain symptomatic. So the goal of this trial to see is in this specific, really advanced population where the next step is putting you under a knife or actually putting you in for alcohol ablation therapy, can putting you on mavacamten actually delay that or actually reverse the surgical indication or the interventional indication for these patients. And what was done in this trial was done over a course of 32 weeks. And in this period, patients got randomized into a 1-to-1 fashion. And the first group who were randomized to mavacamten will continue on mavacamten for the entirety of the 32 weeks. But the group that was on placebo will continue for 16 weeks. And then from 16 weeks onwards to 32 weeks, will continue on the mavacamten group. There were specific areas where you would go in and you would see if they need dose adjustments that take place during the study as per the study protocol. And the primary composite endpoint was decision to proceed with septal reduction therapy prior to or at 16 week, or considered guideline eligible for CRT at week 16. And in a very similar fashion, it can be achieved by one or the second. There were other secondary exploratory endpoints that took place, very similar to the previous trial. So post-exercise LVOT gradient, improvement in NYHA class, Kansas City questionnaire, and basically change in NT-proBNP and cardiac troponins. Again, in a similar fashion, they were relatively very well balanced between each other, no major differences that were noticed. And they were definitely, of course, more symptomatic as you would expect because they're going in for septal reduction therapy. Background therapy was also balanced, but also keep in mind, in comparison to the previous trial, this is a group who has been on disopyramide. Also, in a similar fashion, the gradients are appropriate. It also augments as you move forward in these patients. And they also have an elevated BNP. So with regards to the primary endpoint in this study, not surprising, but also admirable as well. It was met and it was statistically significant. So in these patients, you would notice that 82% of these patients were no longer guideline eligible for proceeding with a CRT by putting them on oral therapy. I think this is an area where you would stop for a second and appreciate the magnitude of change that took place. So I see him in the clinic. I'm telling him, hey, you are likely going to need to have septal reduction therapy. And then all of a sudden, there's a new medication that's available. And I tell him, hey, how about we try to see if this can actually do that? And based on this trial, we do appreciate that a great majority of the patient no longer needed septal reduction therapy. And again, with reference to the placebo, as you would expect, the majority of the patients still remained eligible for septal reduction therapy. What about the LVOT gradients? In a very similar fashion to what we saw before, resting gradients is on the left. The mavacamten group is on the left, is on the red line, and the blue line is the placebo group. You appreciate that there is a significant reduction in LVOT gradients, whether it's at rest or with Valsalva maneuver. Also, in a similar fashion, you would also realize that there is an improvement in the NYHA class in these patients, and some of them are even more than 2 classes of improvement in these patients, as opposed to the placebo group where there is minimal improvement in this group. Again, there was also no serious side effects that took place. It was very well tolerated. What was interesting to see is there was episodes of non-ventricular tachycardia that took place in the placebo group as opposed to the intervention mavacamten group. Another agent that is also in the block is aficamten. So aficamten also is part of Sequoia HCM trial in similar fashion. They looked into obstructive HCM patients that would basically qualify based on LVOT gradient, NYHA class, and a PuVico2 that is less than 90% of predicted. They get randomized into 1-to-1 and they get followed over time to see how they would proceed. And in a very similar fashion, we did appreciate that there is improvement in the peak VO2. The resting gradients also improve at rest and with Valsalva. Their Kansas City questionnaire and their NYHA class also improves. The other question that might come to mind is there any evidence for long-term data? And that also is available right now. And the most robust and long-term data we have comes in from the mavacamten group. So the basically extension of the Explorer HCM, the Valor extended trial as well, and the Forest HCM. And the data is much more longer, as you might tell, because mavacamten has been here for long. But as long as you're on your drug, you persistently show a response. Now, switching gears to the other part is basically sudden cardiac death and risk stratification and family screening. And I think this is really where you need to spend a good amount of time with your patient, because this is what's going to kill your patient, and this is what's going to kill the family. And this is really what's going to kill you as a physician, because, you know, it really is going to hurt you when you hear about a family member who essentially died of sudden cardiac death. HCM death in young athletes is one of the leading cause of death. You know, you've seen these videos about somebody who was, in a football field or exercising, playing soccer or hockey, and then all of a sudden they die and collapse in the field. This is one of the reasons why we're looking. I also want to point your attention that we need to make a distinction between having somebody who's genotypically positive and phenotypically positive or negative. So take this family, for example. So basically, they have the gene positive in the family member here. So the MYBPC3 is positive. And then basically, they continue to have three offsprings. So the first one is basically positive for the gene, and they have LVOT obstruction. And the second one basically also has LVOT obstruction, and he also has the gene. But for example, the third patient right now has the gene, but does not manifest the disease. So this is what we mean by having somebody who is genotypically positive, but phenotypically negative. And on the other hand, the last offspring does not have the gene and has not manifested the disease. And that really falls in what we call by incomplete penetrance. And we see that very oftenly in different type of diseases as well. And that even adds another layer of difficulty with conversations you have with your patients. And that's why having a geneticist is also helpful with you. And this is might seem like a complicated algorithm, but really what I want to tell you here is if you have somebody who's suspected, you do genetic testing in the family, and if you find that the variant is positive, then they have to continue screening. And if you find that the variant is negative, then basically you don't really have to continue screening them. The evidence is not very strong, but some people still continue to screen. On the other hand, you need to know how to screen. And on the right side of the screen over here, this is how you screen your patients. So if you found somebody with HCM, then basically for children and adolescents of somebody who's genotypically positive, then basically at the time of diagnosis and then every 1 to 2 years, an ECG and an echo. And also if you have an adult, then basically it's every 3 to 5 years with an ECG and an echo. This algorithm is what we would use for risk stratification for consideration of ICD for primary prevention and secondary prevention. It's basically an easy decision to make if you have secondary prevention indication. So basically VF sustained VT, then at that point it's a class 1 indication. There is some variation. The right side of the screen is the American guidelines, and the left side of the screen is the European guidelines. The European guidelines uses a clinical scoring system that you would enter specific variables for, and based on that, it would help you decide on the indication. Myself and my colleagues primarily use the American guidelines. It seems to be safer in that sense. The Europeans feel that it might be an overutilization. So at least one of the following is a class 2A. So family history of sudden cardiac death, massive LVH that is more than 30, unexplained syncope. If you have an apical aneurysm, you remember the case that we presented early on that had apical aneurysm and they had evidence of enhancement and they also had VT. And if your EF is less than 50%, then basically a class 2A. And this is why we do Holters for our patients. So if you have a patient and you do a Holter as part of your yearly evaluation and you see evidence of non-sustained VT and they are an adult, then it's a class 2B indication. And if you find that there is extensive LGE on MRI, then that also is an indication with a class 2B. And again, as we mentioned before, it's been a long journey. It's been 155 years, but really things have progressed over the last 10 years. The future remains to be bright. There are a lot of trials that are going in right now and newer agents that are being deployed and explored. But, this is a paradigm shift when it comes to the management of HCM, where this was more of a symptomatic treatment and also moving into oral therapies that are available. Now, to put things in perspective, this was the case that we started off in the beginning. So what took place? She got tested and genetic testing showed that she has the MYBC3 mutation. An ICD was implanted. Why? Because here it's secondary prevention. She had an episode of VT. And also she was started on maximally tolerated beta blocker dosing. She remained symptomatic. Disopyramide was added, and then mavacamten was initiated. And at week 30, this resulted in an improvement in her gradients. So to conclude, as we said, the HCM management is evolving. cardiac myosin inhibitors are a game changer right now. You need to have personalized treatment plans with your patients, discussing the risk, the benefits, and the outcomes and the expectations. And you have to keep in mind that the future continues to evolve. Thank you very much for your attention and for this invitation.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much to Ismail. A brilliant presentation as usual, mashallah. And I'd like to first express my apology. I just had to be squeezed in a patient at the last moment. But alhamdulillah, you managed to start. That was excellent. So, to Ismail, obviously the hope and the really a landmark change in patient care from surgery and alcohol injections into ablation, into a tablet. That's magnificent. And the thing is that there is a very strong science behind it. That's also give us a very great hope. And I believe this is a great message for all our colleagues that hypertrophic cardiomyopathy is no more a nightmare that you're going to tell your patient that, sorry, there is nothing we can do. You probably need to go for this and that, but this needs to be in a higher center, somewhere else, somewhere there. Unfortunately, I don't see, I did not see any active movement in that except in very, very specific centers. So it's a great hope. It's a brilliant hope. And the second point that I really want to emphasize on is that if I am in a place that we don't do any procedure for a HOCM, for hypertrophic cardiomyopathy, whether it's an obstructive or not, I believe family screening is a first priority, because yani, what more I can help bigger than ruling out, not even ruling in this disease in the rest of the family, regardless if they have done echo before or not, if they're complaining or not. So this is, yes, and thank you for mentioning the sudden cardiac death between athletes and what we see in the football fields and what we see in the gyms and so on. And this is becoming, we could hardly hear about it, but now with the different social platform, you really get to see much more of these. So we'll open the floor for questions. If there are any questions.
While we're waiting for the questions, I'd like to ask you a question, Prof. Kamal. First of all, يعني بارك الله فيك في جهودك صراحة. I heard that you had a sick patient that you needed to attend to. فالله يجزاك خير ويبارك فيك. The other issue is, based on your own experience, how often are you in your echo lab doing provocation testing for these patients? Is this part of your standard of care? Does everybody get it? And what kind of provocation testing are you doing?
Wallahi, in the past, we didn't do that much. We tend to diagnose septal hypertrophy or obstructive or non-obstructive, and then we will start arranging for transferring the patient for the higher center or Riyadh or King Faisal, where actually the expertise are there. And we had this question is, do we continue, I mean, with genetic mapping, with the propagation, with all these things, or do we just send forward? And then we refer a patient with an initial diagnosis, then it's better to leave the final assessment. And even we're always hoping for a follow-up at that center rather than just do a procedure and discharge. So we start with that. We refer the patients. Now, we used to see a lot of non-Saudis in our hospital, That would be a great dilemma in which they go back to home and to their country and do it. I don't know how far it is covered by insurance these days, but the past 3 years, the number of non-Saudis has dropped significantly in our center. But yes, this is the answer. We don't do it because we tend to send and hope that the whole severity package will be diagnosed at the center. Wallah, Ismail, nobody's asking any questions.
I think that means, we did a good job, I hope, and we answered
Wallah,
most of your questions.
with this presentation that you did, mashallah, people are just happy about it, mashallah.
I want to also point the attention of the audience to something that I did not mention on the group, which is atrial fibrillation and HCM. So I think there's another important point that I want to stress out is if you have a patient with HCM and atrial fibrillation, there's no CHADS VASC score in these patients. You directly start them on anticoagulation therapy, and DOACs are very fair game, and they're proven to be also successful here.
Agree, 100%. Really, really agree.
I've put my email and my contact in the last slide for those of you who have questions, for those of you who have HCM patients and you want to collaborate, because right now we're working together as a group who are interested in taking this forward. So if you have referrals, if you have patients, just push us an email and we'd be more than happy to assist.
Hey, Dr. Ismail, I think we'll wrap up now because, mashallah, we have 55 audience, but I hope that, I know that the presentation was, covering fairly all our raising up questions. Right, Dr. Ismail, thank you very much again for a wonderful presentation. And thank you very much also our 55 participants. And I wish you a great evening and a great patient care. Jazakumullah khair. Thank you, Kunuz Ritaj, for the organization. Assalamu alaikum wa rahmatullahi wa barakatuh.